of the Commission. I much appreciate the opportunity to speak this morning. My name is indeed Gideon Foreman. I'm Executive Director of the Canadian Association of Physicians for the Environment. We're an organization of several thousand doctors and members of the general public, concerned citizens working to protect people's health by protecting the planet. We have a number of concerns around nuclear energy, but today I'm just going to confine myself to one of them, and that's our concern that the 10-kilometer potassium iodide distribution zone around the Bruce facility is inadequate and should be increased. Our doctors know that based on experience in Fukushima and Chernobyl, a reactor accident may require residents living as far away as 100 kilometers to protect themselves from radioactive iodine. We believe that the current 10-kilometer distribution requirement, while useful and praiseworthy, should be viewed as a minimum standard only. Prudent public policy, we believe, dictates that KI pre-distribution should be undertaken within a far larger area. Now, in determining appropriate standards for Ontario, we urge you to look at international jurisdictions. And you'll note, for example, that Switzerland is pre-distributing KI to all persons living within 50 kilometers of its nuclear plants. And Belgium's Conseil de la Santé recommends selective pre-distribution of KI to pregnant women residing within 100 kilometers of that country's nuclear stations. We know these Western European nations have a reputation for high living standards and smart health policy. We also know that Switzerland has actually carried out accident modeling for a major incident and bases its KI distribution policy on this modeling. As you know, the Swiss nuclear regulator modeled 3 level 7 accident scenarios, and on the basis of this research decided last year in 2014 that KI pre-distribution would be extended to a 50-kilometer radius. We urge the CNSC to follow these European standards in setting standards for the Bruce facility. In summary, this would mean pre-distribution of KI tablets within a radius of 100 kilometers for vulnerable populations, for example, pregnant women, children of school age, and 50 kilometers for the general population. We know our recommendations are considerably more ambitious than the current 10-kilometer requirement, but as a doctors' organization, our overriding concern is public health. And in this situation, protecting public health means, in our view, following the most rigorous standards available, which are those employed in Western Europe. We also know that CNSC shares our belief that Ontario's emergency preparation measures should be nothing short of world-class. Thank you, Mr. Binder, and members of the Commission.
Thank you. Question? Dr. McKeown.
So thank you for the presentation.
Pleasure.
We heard yesterday from Bruce that they are individually distributing within the 10-kilometer and pre-distributing to centres within the 50-kilometer zone. Do you see that as satisfactory, or do you think that the individual distribution should be extended to that wider zone?
The latter, Dr. McEwen. We think the 10-kilometer is a good start. We are concerned about the stockpiling only because of the concern that people need to access the KI tablets so quickly. As you know, the U.S. Food and Drug Administration, for example, says that they're best taken within 3 to 4 hours of exposure. Our concern as a doctors' organization is if there's just stockpiling, it will be some time before people actually access them. So that's why we're arguing for the actual pre-distribution within the 50-kilometer radius.
So I guess a question to Bruce. What population does that 50-kilometer zone increase the 10-kilometer zone population by? And are you planning any sort of education or information campaign within that 50-kilometer pre-distribution to encourage people to pick them up within an earlier time frame than an accident? Because I think the assumption always is that people will only pick it up at the time of the accident. And if you're doing that latter, how will you monitor it?
So the population within the 10-kilometer zone is about 1,500 people, and out to 50 kilometers, about 65,000 people approximately. Yeah, we will certainly have the pills out there and encourage people to pick them up, or more appropriately, the province and municipalities will, and we'll provide the support to help do that. And people are allowed and encouraged to do that. I think, though, when you consider pre-distribution out at large distances, you got to look at both the nature of the contamination, how it would spread, and how fast it would spread, And the model suggests that actually you've got significant time either to distribute, allow people to pick them up, or simply move people out of the way. In my view, the latter is always preferable to the other. The KI pills are really, I think, intended for those who may be in a situation where they don't move, so closer to the plant, or for a very low emission event where staying in place is a feasible option. But again, I'm kind of out of my jurisdiction here. It's in the provincial territory, but our belief is a 10-kilometer pre-distribution is more than adequate, and the stocking out to 50 with people certainly encouraged to pick it up, and like I say, examining sort of more vulnerable populations out in that area and encouraging them to stockpile is the right approach. There is certainly an issue of how effective maintaining KI pills. The further away you go, the more difficult it becomes to keep of the transient population and manage it at any rate. So,
Mr. Knoll, I think you came forward to say something.
If I may, Mr. Chairman, Dave Nodwell, OFMEM, for the record. I thought I would take the initiative to come up and comment on it because the province is very involved in the KI distribution, as you know. I did want to clarify with respect to the secondary zone, what we're currently calling the secondary zone, that it is not strictly stockpiling, but we are targeting, and this is based on science that has been applied to this, to the most vulnerable in that area that would be subject to requiring KI, and specifically children under 18, pregnant mothers, and so forth. So those are the ones that, based on our assessment of dose rates, would be in most need of the KI in a very, very large accident. Based on analysis, we're very comfortable with the 10-kilometer distribution to everybody in that zone. We support that, and we're working towards achieving that this year, as you know. The trigger for KI is a dose rate of 50 millisieverts to the thyroid, and that's based on the most vulnerable. So in terms of a large release hitting that dose rate beyond 10 kilometers, the odds of that are very, very, very slim. But despite that, we are distributing in the secondary zone to the vulnerable. I should add as well that within that secondary zone that it would be available to all those who want it. So they will be receiving public education and awareness about KI, and will be able to supply or obtain a supply of KI pills for their household if they so desire. So I just wanted to clarify that point, Mr. Chairman.
So can I just follow up on that? Within the 50-kilometer zone, you will have enough KI pills for the full 65,000 population. Because my concern of using a cutoff based on millisieverts, I think it does two things. One, it ignores human nature. I mean, I'll remind you that people in Vancouver, and indeed in Alberta, were asking for potassium iodide pills after Fukushima. I recognize there is no benefit there, but they were asking for them. And secondly, I think the public perception of risk is probably not going to be satisfied by a simple calculation based upon a dose rate.
To answer the first part of the question, the intent is that there would be adequate KI supplies for the 50-kilometer secondary zone. So that is the case. I certainly concur with public perception and the demands for KI. In fact, my office received requests from as far away as Idaho immediately after Fukushima looking for KI pills. So that is a part of it. I think really in terms of the analysis, and the calculations, that has driven the determination of what's required and where. But it's important to know that the Chief Medical Officer of Health is the one that is making the call in terms of taking potassium iodide and issuing that particular order. And based on the Ministry of Health's guidelines and Health Canada's guidelines as well, the threshold would be 50 millisieverts to the thyroid for that order to be initiated.
And just help me remembering, my memory is that there's been, as the intervener suggested, there's been extensive benchmarking on the international comparison. I thought there was a particular study that was done that looked at what other jurisdictions are doing, and it's involved the medical authorities and some of the CNSC contracting. Did I got it right?
Raul Awad, for the record, that's right. We did a comparative study between what we are proposing at that time in 210.1 and what other jurisdiction is doing. And fortunately, the SARP, or the severe accident study, came, and that confirmed what we put in the 210.1. I think our model, it's totally different than the others, but it's supported by a study.
Dr. Barrio?
Thank you, Mr. Chairman. Thanks for your presentation. One of the questions that I have really is that the Association of Physicians for the Environment notified the Canadian Medical Association of what their suggestion, or the College of Family Physicians of Canada, because they would be the liaison, if you want to, between the treating physicians and the population. College of Obstetrics, for example, with regards to pregnant ladies. When you see a patient for the first time, as you know, really a pregnant lady, for example, you're going to order some things, the folic acid, you're going to order iron. You could also order KI pills if you have any concerns with that. So have these people been involved in the loop at all?
We have not worked with them on this particular issue. We do collaborate with Canadian Medical Association on other issues. We have not specifically on this KI distribution issue. It's a good suggestion. It's not something we've taken up yet.
Thank you. Thank you, Mr. Chairman.
Anybody else? Any final comment? Bruce. Oh, sorry. Missing it.
Hi, James Cognac for the record. And sorry I had to step out there for a minute. I just thought it'd be helpful to just maybe for the record just identify if we've really obviously focused some of the discussions throughout the hearings on the initial 10-kilometer area. So I think maybe it's helpful for us to just identify in a little more detail what we have taking place in the 50-kilometer area, and I think it'll address one of the questions the Commissioner just asked. So obviously the focus is beginning on the 10-kilometer area. However, in parallel, we're advancing some initial outreach in the 50-kilometer area to prepare for a broader launch this summer. A few of the initiatives we've carried out with respect to the 50-kilometer areas, we've held a lunch and learn sessions with local physicians in both Saugeen Shores and Kincardine. And I think the important element there is that there's literally thousands of interactions between local residents in that 50-kilometer area and their local physicians, and this is the type of kind of conversational issue that could come up. So one of the things that's very important to us is that we work with local physicians around the site so they understand the background behind KI. Because obviously one of the pieces of feedback, and I don't think it's surprising, is that we're getting related to KI pill redistribution, is that, as Mr. Saunders and Newman articulated on Monday evening, our plants are safer, and the distribution of KI pills is to enhance safety. But for a lot of people, receiving something or information on something that may not have been as top of mind can lead people to a different impression. So before we launch the 50-kilometer within 50-kilometer outreach, it's really important to us that we work with those stakeholders, physicians, the school board, the type of people that outside of Bruce Power that people get confidence from One of the things you'll see, and it was mentioned in the oral intervention from the Grey Bruce Medical Officer of Health, but in a lot of our videos, the website we've released is we're really relying on Dr. Hazel Lena, our local medical officer of health, who, of course, the public has a lot of confidence in the local medical officer of health, to really deal with a lot of the kind of personal questions that people will have on this, because there's no doubt that we can do all the communications in the world, and I think we've done initially a good job with that. But it's going to be that personal contact that is going to be very important. So when a member of the public goes and talks to their physician, or they call the municipality, or they call Bruce Power, or they call the medical officer of health, that there's a consistent set of messages and opportunities to get information from a range of sources. So it's something we're very aware of, and you may have seen in the media. Just last week, we signed an MOU that we announced between all the hospitals in the area, both hospital corporations, and we provided some funding through that MOU to actually educate all first responders, whether it's nurses, other healthcare professionals, on these types of things. So it's going to be an ongoing effort, but I think the important step for us is to reach out to those people before we do the broader release.
Okay, thank you.
May I make a final statement?
Absolutely.
And, President Binder, I think just in calling for this wider pre-distribution of KI, we just want to make clear that the problem with the stockpiling approach is that people just don't seem to take it up. There's an interesting document I have here, President Binder, some research done by OPG in Durham. This was done in December of 2013, and the researchers asked people about sirens and potassium iodide pills, these sorts of things. And one of the results of that research was, and I'm quoting here, almost none of the participants in the focus group had obtained free pills that had been advertised in regional communications or pamphlets. So it's not that people don't know about them. They, in some cases, do know about these stockpiles, but they seem not to act on it. And that's the concern that we have. We need to put the pill into people's hands rather than rely on them to pick them up.
Okay. Staff want to...
Dr. Shandor Demeter, as a physician advisor to CNSC. I just wanted to make sure that there was a clarity. The intervener initially said that the benefit of the pill is within 2 or 3 hours, and I want to make sure that there's a clarity that 2 to 3 hours is before they are exposed. It's about a greater than 95% chance of blocking if you know that the wind is coming and you take it before you're exposed, about a 90% chance of blocking if you take it at the same time you're exposed, and there's diminishing returns thereafter. So it's not to say that that's not going to happen, and the access is there, and you have to deal with the demographics and the population density. But I want to make sure that there was clarity to that statement that within 2 or 3 hours is not after they're exposed, it's before they're exposed.
Okay. Thank you. Thank you for your intervention.
Thank you very much.